Going to be $13 million savings going right to frontline health care. That's not the case. Now he takes my advice. Now, Madam Speaker. I don't know. I almost turned blue prior to election telling them you should take my advice and not go down this road the way they're going. And I know a couple of months ago the minister said that's not the case. We can't do it right away. There's other things at play, like severance, like people leaving the system that have contracts with the government. And they said at that time, million-ish, I think is what was said. And now, of course, we see yesterday that they're indicating about $5 million that may be saved, minimum, sometime in the future. But the concern I have about that, Madam Speaker, is that there was no plan. So now, those senior management that are within the Department of Health have to come up with a plan for the government, have to figure out how this is going to work. And as I said earlier, that's taking them off issues that have been long-standing in the province. You know, we worked hard on trying to address as many issues as we could when we were in government. I indicated from the $14 million that we saved in health administration costs, I think we reduced VP positions by 18 or 19 over our mandate. Significant, I think. 18, 19 less VP positions in health administration. The next step was, of course, to try to get some of those CEOs to amalgamate. That's where we were going. And I mean, you don't have to take my word for it. I know when Ms. Knox was introduced as the new CEO, she said for years now that she had been working with other CEOs in other districts to make sure that there was the ability to support each other as districts across the province. But one of the things we haven't heard from, and I think it's due to the busyness of this file, is what's going on in long-term care. There's still wait times. They haven't been eliminated unless I missed that news release. I missed that news release. There was a number of commitments made from the previous government around increasing the long-term care beds in the province. If I'm not mistaken, the Premier now, who was opposition leader, said that they would honor those capital projects. We were going to work together too. Yeah, thank you. Yeah, that they would agree with that. But I haven't heard of any addition to long-term care beds and facilities in a year. Continuing care is hugely important. Trying to keep people in their own homes. I know our last year in government, we put $21 more million in continuing care, in home care support, so that people can get the support at home. That's where they want to be. They don't want to be in a nursing home. There's not too many. I don't think I've ever met anybody as Minister of Health or as MLA that says, oh, wait, I can't wait to get into a nursing home. I've never met them. Unfortunately, people do end up in long-term care facilities, and there's so many dedicated women and men who work in those facilities who provide care. Most of the time, it's towards the end of the life care of Nova Scotians. But we haven't heard anything. I haven't seen news releases about more home support for Nova Scotians. In another area, Madam Speaker, that was extremely important to everybody, and I believe the current Minister of Health asked me, I don't know how many questions, on ER closures. We have legislation on the books today that require the government to bring forward an ER accountability report that tells Nova Scotians how often the ERs are closed across the province. It's legislated. It's somewhat overdue. I think maybe tomorrow I'll get a question to the minister, so maybe he'll get me an answer. Where's that report? How many ERs have been closed in the last year in Nova Scotia? And with that accountability report, not only do government have to say where those ER closures are, but they have to say why they closed. Was it personnel? Was it some other reason? And also what they're going to do to fix it. And you know, it's no secret. We've talked about this many times as a government and as MLAs in our party that we recognize emergency rooms and how vital they are in rural communities, and brought forward a change in model of care that is now being looked at across the country. and that's, of course, the CECs that we have throughout Nova Scotia. We have them in communities that, for far too long, continue to have no access to emergency care, that continue to see healthcare workers be sent home because maybe the physician there who couldn't work 48 hours in a row had to take some time off, so they just closed it. And at those opportunities, we lost the ability of healthcare providers like nurses and paramedics from being able to provide care that they can, allowing them to work to their full scope of training. And that really was kind of the background of why we needed to look at something to improve that. And of course, we had Dr. Ross, who is a well-respected physician, an emergency room physician, not only respected here in Canada, but around the globe, visited every single ER in this province, every single one of them, to try to find out what was the issue, try to hear firsthand, right ground level, what the concerns were in those ERs. And he came back with the Ross report, which really was the framework of how we move forward, how we made the decision to introduce collaborative emergency centres to places like Parrsboro, Spring Hill, Tatamagouche, Pugwash, Annapolis Royal, Musquodoboit Harbour, Musquodoboit Valley, and New Waterford, which is a mobile CEC, and supposed to be soon was Lunenburg, which we haven't heard anything from the government of what the delay is, and I'd be interested to see if there has been an increase in emergency room closures in the last year. During our mandate, every year we reduced emergency room closures. Every year, Madam Speaker, they went down. North Sydney, I've been reading recently, is being closed a lot, and there are many reasons for it. And that's why the government needed to continue to work on that file, to try to make sure that people in North Sydney had access to emergency care. There was some kind of solution to their issue. And that's the other part that I'm so against this piece of legislation, is the fact that we're going to lose, I believe, that communities are going to lose the ability to effectively propose changes to how healthcare is delivered in their community. The Premier told me today nobody calls her CEO of the Health Authority. Well, I got to tell you, when they don't have anybody in their community to look at, I think they're going to call the CEO. And that's why I said I hope it's a 1-800 number, so people don't have to incur long-distance charges from Parrsboro or from Glace Bay or wherever else they're calling from. And the importance of ensuring that they have access to communication and the ability to propose changes goes right to the model of the CECs. So this is a total change of model of care in emergency room and care that people get. And we didn't come forward with the CEC model and say, here you go, Parrsboro, here you go, Spring Hill, Tatamagouche, Pugwash, those other ones. Here's the model, just implement it. Every one of them are different in some capacity because each community's needs are different. I know we're one province and we're less than 1 million people. I've heard that's the reason why they want to amalgamate all the district health authorities. That's fine to say, but we're a diverse province and their needs and communities are different, especially in healthcare. One area of the province may need more nurses. Some may need more paramedics. Some may need more surgeons. Some may need more cardiologists. It's going to be more difficult, I believe, to figure out what the needs of each little community are by having this mega board. And we wouldn't have been able to introduce the CEC model in that manner. It wouldn't have worked in New Waterford. New Waterford's a mobile CEC because the interaction with the local board and the community members recognized a big issue in New Waterford. And that was a lack of transportation sometimes for individuals. And some low-income individuals, single parents, who brought forward their concerns. You know, that one of their concerns was late at night, if I had an emergency, I couldn't get all the kids I didn't have access to get to the emergency department. I called an ambulance, even if it was a less minor issue. And I remember there's been criticisms over the years that one of the issues why we have crowded ERs is that people go there for everything and anything. And I've said this before, it doesn't matter why they go there. If that individual feels that they have a health concern, that they're concerned with that. They go to what's available to them. And in many communities, it's the ER. That's the only thing that's available, especially after hours. So in a place like New Waterford, we were able to look at and hear from that community that there was a need. So the Mobile Collaborative Emergency Centre came to light. And, I understand at first there's some reluctancy to move to a new model of care, but I think it's serving that community well, and it's a model that's being looked at, as I said, across the country. I continued to say, when I was Minister of Health, to the department, I wish we could have patented the CEC model and got revenue and royalties, because we had jurisdiction after jurisdiction coming to Parsboro and Pugwash and Spring Hill to find out what it looked like. How is it working there? And I got to tell you, when you go to Parsboro, small little community, they weren't too sure about this at first. But because there was an ability to have leaders from the community who were on those health authority boards, who were their neighbors, who lived next to them, who had family members that used the same hospital and ER that they did, they were able to convey to them that, listen, we need to give this a try. What we've been doing for decades hasn't been working, hasn't been meeting the needs of those individuals. And because of that connection to that community, I believe from the health boards and from the CEO of that area in Parsboro said, yes, we'll allow our community to try this. We'll be the first in Nova Scotia to have what a collaborative emergency center is. I got to tell you, once I became minister and got up to Parsboro and went in there, they were very proud and always had the offer to make sure that if anybody was asking about collaborative emergency centers, that you brought them to Parsboro. And the one thing they wanted to make sure was that nobody came in and changed what was going on there. And it really shows, I think, a small community like Parsboro that they were willing to accept some change, embrace a new model of care and healthcare. Sounds crazy when we first talked about it. Oh, I don't know. What do you mean? You're going to change who's working here and who do I see? But once they started interacting with the healthcare providers that were there, they realized how dedicated they were, the level of care that they got, and that, you know what? Yeah, this is better run. I remember having an elderly lady tell me, I used to wait 5 to 6 weeks to see a physician. 5 to 6 weeks just for some small ailment, which usually transpired into something more serious because they had a chronic disease, which ended up that they couldn't be seen at their local ER. They ended up going to the regional hospital and sometimes ended up in Halifax, all the way from Parsboro, because they had to wait 5 weeks to get in to see their doctor because they had some breathing problems, and by the time they got in there, they needed a higher level of care. Now they have same-day, next-day service, and they said they wouldn't have it any other way. So it's just one example, I think, of the approach that we took that will be different than what the current government is going to take when it comes to trying to address health administration costs, trying to make sure that people have a voice in local communities. I know initially they said they're going to have one board, and then it kind of morphed into 4 regions. And I would predict within the next few years, we're going to see exactly what was just announced from the new Premier of Alberta, and that's a rural healthcare plan. And the reason for that is because those communities were not being heard. The issues in those small rural, and especially in Alberta, some of them are remote, you can only fly into their communities, weren't being heard by a super mega board. And over the last 2 years, Alberta has kind of reverted back to ensuring that that input is there from communities. So what the heck did they do it in the first place for? Why did they pay $50, $60 million for people to leave the system when that $50 and $60 million could have been spent in rural health care in Alberta? The question here that we can't get from the government is, how much is this going to cost us? The finance minister said in her update, Madam Speaker, that this will cost us money. They finally admitted that. How much? Who knows? All they go back, oh, well, we're going to save $5 million now. That's this week. That's this week. Million-ish. $5 million. There is a cost here, and we can't get that from the government. How much money is going to be diverted from health care? How come, one of the things we did with the $14 million was, I said earlier, introduce an insulin pump for children, and we increased dental coverage for children in Nova Scotia. Maybe some of that money that's being spent to amalgamate could go to even increasing more the age limit for dental care. Maybe help seniors, get a program to help seniors for hearing aids. We know that they're struggling every day to try to pay for that. Maybe it should go towards lowering the premiums that our seniors are paying for senior pharmacare. Those are the things that we could use the money that we're going to pay CEOs to leave that I would have rather seen happen. As I said at the start, I agree with having to reduce health administration. That was something that we were committed to in government. I know the Liberals say they're committed to it, but what you don't want is the chaos. And I see in Bill 1 that that's all they're doing, creating chaos. You have a deputy minister already apologizing to healthcare workers for the upheaval of their working environment. That's in my mind, that's craziness that we have a deputy minister having to apologize to healthcare workers already. And we're not going to see any real true results or a vision for this new mega board until April 1st, 2016. I mean, I can't see any other, I can't believe they're going to waste the time, the energy, and the money to get us to that point. They should have done their work prior to this, Madam Speaker. And I tried, as I said earlier, I tried for months and months to say what other jurisdictions, what their experience was, and how they all seen an increase in health administration costs. But that was on deaf ears. No, we're going to save $13 million. It's $5 million now. It was difficult for us to save $14 million over 4 years. But I can assure you that we did not create chaos within the healthcare sector, that our Minister of Health, our Deputy Minister of Health, did not have to apologize to workers over those 4 years about the upheaval within the sector because we were trying to save health administration costs. It was actually the contrary. CEOs across the district health authorities, board members across the district health authorities, people within the Department of Health, all realized that we needed to do this and save money, and they all came forward with ideas. Every single one of them. There wasn't one district out there that said, no, we don't believe we need to save money. We're going to keep what we're doing. None of them said that. They were all on board. And Ms. Knox mentioned that in her speech after being announced, that she had been working with other districts over the years. There's no walls up between the districts. There are some barriers, but those walls were being taken down, Mr. Speaker, by the previous government. We had Nova Scotians who had choices, if they wanted to, move to other districts to get care. That's why we had published wait times. That's why physicians had access to lists of surgeons and their wait times, so that they could make the best decision possible on referring their patient to a specialist, to a surgeon. My own father was in Bridgewater, I believe, for surgery a couple of years ago. And so there was work being done to take down those walls around districts. We look at the mammography program here in the province. There was one number that you called. And if you lived in Yarmouth, you could call that number and say, well, it's getting close to Christmas. I need my test done. I'll be in Halifax. I'll call and see if there's an opening in Halifax. I've heard that directly from people from Yarmouth. who made an appointment in Halifax because they were up here visiting family. This one was Christmas shopping, but was able to gain access to the healthcare services here in Halifax. So this vision that people, you're going to break all these walls down, aren't really there, Madam Speaker. There was a transformation happening within the healthcare sector that seeing a better, I think, sharing opportunity between districts, surgeons who were working in multiple areas. And there was still work to be done. I would agree with the minister. But in his office, that's what senior management should be working on. And I remember reading through some of the emails, and I think it was a comment in maybe question period today, that, listen, a nurse can't go across the harbor and work in Dartmouth General. Okay, you could say that, but you also have to ask more questions. Okay, what nurse are you asking to move over to Dartmouth and work in Dartmouth? Is it someone who is an ER nurse and they need a nurse in the OR over at Dartmouth General? If that's the case, then you might not want the ER nurse. Not that she's any less trained, but she's trained differently. There are differences within the profession of nursing, for example. ER nurses do a different role than OR nurses. And if you've ever been in OR, there are different skill sets there. They're all trained the same, I would agree. They're all nurses, but they bring their own specialty to wherever they're working. And it's not as easy as it's being said, just they're not allowed moving there. Moving nurses from floor to floor. If you have a nurse who's been working in cardiac for decades, and then all of a sudden just move them all of a sudden down to the gynae or another area, I'm not going to say that they can't maneuver, but they may not be as up to what really goes on those floors. So there was ways of addressing that. And it's not telling that nurse from Halifax that they need to belong to the same union as the nurse in Dartmouth. That has nothing to do with their competency. Has nothing to do with their scope of care that they can provide. Has to do with what kind of additional training did they get after they graduated. And that is something that senior staff should be working on. I would agree with that. That we need the mobility part of our healthcare providers, because that was really so that we can utilize them better. We know our population is shrinking in Nova Scotia. It's no secret. And I don't think we could have any targets that would be achievable that are going to address the sheer reduction in population in Nova Scotia. So what we need to do is work smarter. Allow our healthcare workers to be utilized in situation environments that use their full scope of practice and full scope of training. And that was at the essence of collaborative emergency centers. As I said earlier, because if a physician may have worked 24 hours and then spent 12 hours at the regional hospital looking at patients, they had to take 12 hours off, so they closed the emergency department. You had nurses there, you had paramedics there that are fully trained, that can work on people, that can assess people. That's their whole job, is assessing what the needs are of residents when they come in for an emergency. It's not the physician that meets you at the door when you go to the ER. If you go to the QE2 down the road here, it's a paramedic. Because the paramedic can train and understand what is going on with you and where you need to go then. You go to other hospitals, it's not the doctor that meets you at the door when you walk in, it's the nurse. Because they're trained to understand what's going on and make a decision. And in healthcare, that's what we need. We need decision makers. And if you're trained properly, you can make a decision on what care that person needs. So you go into Parsborough, and they recognize that maybe they're having a stroke. That nurse or that paramedic sitting there who see that person coming in or who assesses that person, they're not yelling for the doctor that might be there. They're calling dispatch saying, can we have the life flight here? Can we get an ambulance here so that we can get that person to a stroke unit so that that patient can have a better outcome as they progress through the healthcare field. So that's what we need is decision makers within healthcare and utilize them to their best of their ability. This piece of legislation doesn't talk about that. all it talks about, as I said earlier, is where you're going to end up. And I got to say, reading through some of the letters, and I haven't forgot, I'll table this before I do it. That's part of their concern, is that, you know, they belong to a union that many of them feel represent their values and where they're going. They fought for their benefits package that they have, and they feel it's wrong for government, and you can paint it any way you want. The government's going to make a decision on where they go. They're you know, unless they, I think I read in the bill, if the unions, right after the passing of this bill, if the unions don't agree within 7 days of a mutual mediator, then the government will appoint one. So, you know, the likelihood of getting them to agree on that is you know, I'm sure they're going to try. And that's the thing that's frustrating about all this, is that the unions have been trying. They recognize that the new government came in, there was going to be a new direction, that they were going to go forward with this amalgamation, but they wanted to work on seeing if they could come forward with a compromise. And they worked all summer, and some of them feel betrayed, is what I heard and read in many comments. So instead of trying to maximize the use of our healthcare workers, put them in an environment that you know, really compels them to work to their full scope of practice, which I think improves their working environment. When you're working in an environment where you have to do things that really you're not trained to do, other people should be doing it. I mean, I think the environment, like collaborative emergency centers, really bring forward the responsibility on those nurses who are evaluating those people who are coming in, those paramedics, and some of the CECs that have paramedics, to make that decision, saying, you know what, I'm trusted by our healthcare system to make these important decisions about the health well-being of an individual. And I think in Bill 1, we don't see that. We don't see where it's going to, or how it's going to improve healthcare. We don't see how this is going to be better for the healthcare workers, and there's a fear that there's going to be a race to the bottom and take the smallest package or benefit packages from each union, and that's what is going to be forced down their throats. That's what they're feeling. They're feeling uncertainty, and this does nothing. This bill does nothing. If anything, it hurts morale of the healthcare sector. We heard it through Bill 37 time and time again. You know, I want healthcare workers to be out there worrying about you know, healthcare. And trying to figure out, what do I do when that next case comes in if it's a certain ailment? Not, oh, geez, am I going to lose some of my benefits? Am I going to get less vacation? Is my pension at risk? My vacation time? Whatever it is. They shouldn't be worrying about that when they're sitting working a shift for 12 hours at the ER or on a floor or in the OR. I don't want that, and I think that's why we feel compelled to ensure that we voice our concerns about this piece of legislation. And that I look forward, and I hope government members listen intently when this gets to law amendments, because I'm sure there'll be a few people coming in giving their opinions about Bill 1, Madam Speaker. Thank you.
The honourable member for Sackville-Cobequid.
Well, thank you, Mr. Speaker, and you know, it's a pleasure of mine to rise and speak on Bill 1. But I'm not only speaking for myself, Mr. Speaker. I'm speaking on behalf of the many people, Nova Scotians, who tried to have a voice on this piece of legislation, but weren't allowed to, Mr. Speaker, because of the motion passed by the Liberal members of law amendments that limited the time allowed, even though, Mr. Speaker, even though there were Nova Scotians wanting the opportunity to come forward and voice their opinion on Bill number 1, Mr. Speaker. And many of them did not have that chance. So I'm pleased to be able to bring their voice here to the floor of the legislature, Mr. Speaker, on their behalf. I too, for a brief moment, and with all respect of the Speaker and your authority, want to mention my experience over the last 4 days and my observation of the security measures that have taken place. I haven't been in the House as long as my colleague, our leader. I believe she's going on 17 years. But